If you see the criteria here, so these are the various features when you call normal, rapid upsloping, minor ST depression or slow upsloping. So again, these are the pictures when you have a horizontal ST depression, downsloping or ST elevation. When the ST elevation is there in a non-Q wave lead, it is significant for ischemia. When the same thing ST elevation happens in a Q wave lead, then you don't take it into account. It can happen just because the segment is aneurysmal or akinetic and it is not an ischemic response. So here in this picture you see that the J point at peak exertion is depressed at 2.5 millimeters. The ST segment slope is 1.5 millivolt per second and the ST segment level is depressed about 1.6 millimeter at 80 milliseconds after the J point. And this slow upsloping ST segment at peak exercise, it indicates a ischemic pattern, whereas in recovery you can see a typical positive ST response, ST segment depression. So here this is a false positive exercise test where the ECG normalizes in the early phases of recovery. This is a ST elevation happening during exercise, and this usually happens because of high grade coronary narrowing which causes a transmural ischemia. It can even happen during coronary vasospasm. And what are the confounders of exercise treadmill test interpretation? When the patient is on digoxin therapy, it produces an abnormal ST depression, and if the patient has got a left ventricular hypertrophy, the specificity is decreased, whereas the sensitivity is unaffected. Similarly, left bundle branch block, if it occurs during exercise, it has no association with ischemia. But when there is a resting left bundle branch block, no level of ST segment depression will confer any diagnostic significance. If there is a left bundle branch block, please don't do a treadmill test. And the presence of right bundle branch block does not appear to reduce the sensitivity, specificity or predictive value of a stress ECG. And as I told earlier, beta blocker therapy, for routine testing, it is not needed to stop risking the beta blocker therapy, especially when the patient exhibits possible symptoms of ischemia or has hypertension. Whereas you can maintain the sensitivity by using a score of 0.5 millimeters ST depression as a criteria. In other interpretations, so exercise-induced arrhythmia, non-sustained VT is uncommon but worrisome in the history of syncope, heart failure, etc. Whereas other arrhythmias are of benign. And silent ischemia, whenever you have a painless ST segment depression, the patient can still have ischemia but has a better prognosis. And ECG stress test can also be done during acute coronary syndrome when the patient is pain-free, normal, when the ECG is non-diagnostic, or when the ECG is unchanged from the previous tracing with normal cardiac enzymes. This can be done for the processing the prognosis and for assessing the quality of life. And exercise testing can also be done after MI. It's a submaximal test can be done just before discharge, where the patient can be exercised to about 5 to 6 METs or up to 75% of age predicted maximum heart rate. This can be done after 3 to 4 days just before discharge. Or a max, you can subject the patient to a maximal stress test after about 3 to 6 weeks of a heart attack, so which is useful for prognostication and rehabilitation. And the non-ECG observations, these are even more important than ST segment changes in the ECG, like fall in blood pressure. That is whenever there is a blood pressure fall or there is a failure to increase the blood pressure beyond 120 millimeters of mercury, then it carries a bad prognosis. Similarly, when more functional capacity, if the maximal working capacity is less, then the patient has a bad prognosis, especially if the patient is unable to exercise more than 5 minutes, it is a bad prognosis. Similarly, when the heart rate responds, the patient, when the heart rate fails to increase appropriately with exercise, it is associated with an adverse prognosis. So similarly, when the heart rate fails to come to normal, that is when there is abnormal heart rate recovery, that is a slow heart rate deceleration.
Sir,
Then, finishing. So, finally, so Duke treadmill score is calculated by multiplying the duration of exercise in minutes into 5 times the maximal ST segment deviation into 4 times the treadmill angina index. If it is going to be less than -10, it is high risk. If it is going to be more than +5, it is low risk. So, thank you, sir. Thank you.
Dr. Kannan has extensively enlightened about the stress test. As there is short of time, we will not encourage questions now. Any questions you can discuss with Dr. Kannan subsequently in the T sessions. Thank you, sir.
Thank you.
Thank you, sir. I now request Dr. Martin Green to hand over a token of appreciation to the speaker, Dr. Kannan. I request Dr. Kannan to hand over the certificates to the chairpersons.
The chairpersons for the next session are Dr. Paul Verghese, cardiologist at Unity Hospital, Mangalore; Dr. Peter George, Professor of Medicine, Father Muller's Medical College, Mangalore; and Dr. Prashant, Physician, Father Muller Medical College, Mangalore. I invite them to kindly take their seats. I invite our speaker, Dr. Amit Vora, onto the dais to speak on how do I interpret ECG in a patient with a pacemaker. I request the chairpersons to introduce Dr. Amit Vora.
Good morning. Let me introduce Dr. Amit Vora. He is well known to all of us. He is our honorary secretary of ISC. He is an electrophysiologist at Mumbai and associated with the Department of Cardiology at KEM Hospital as associate professor. Sir, over to you.
Thank you. Good morning to all of you, and let me take this opportunity first of all to thank Dr. Prabhakar and his entire team and everybody at Father Muller Medical College for having put up such a fantastic educational feast. All of us have benefited, including us. And before I start my talk, one of my friends has a habit of sending me a quote of the day, a message every day. And the one he sent today, I thought that I should share it with you all. It states that intelligence is like an underwear. It's important you have it, but it's not necessary that you show it. So, having said that, let us try to make an intelligent effort in trying to look at ECGs in patients who have a pacemaker implanted. Now, some of these ECGs you might have seen earlier in the ECG course, but I'm going to try and help you to tease out more information from these ECGs. So what do you look when you see a ECG with a pacemaker implantation and you clearly see a large pacing spike? Now the largeness of the pacing spike tells you one thing, that this is likely to be a unipolar pacemaker. Pacemakers can be unipolar or bipolar. Bipolar are the ones which are conventionally now available. They are still programmable in the unipolar mode. Bipolar pacing spikes are very small, and I'll show you some examples of that as well. So the pacing spike is there, and which chamber it is capturing? You see the QRS coming up. So obviously this is a ventricular capture, and it's a ventricular pacing type of a pacemaker. That's the information you have. And most important then would be, is there any sensing chamber or what's happening to the P waves? And if you see here, you see isolated P waves randomly occurring at any point in time, telling you that the atrium is not being sensed by this pacemaker at all, and therefore this is a single chamber pacemaker. And then you need to look at the QRS morphology. It shows a left axis deviation. If you see the precordial leads, you see a QS pattern right up to V5, V6, telling you that the location of the lead is in the RV apex. So this is all the information which you get, and you need to look at the STT segment as well. And what does the ST segment show? It shows that it has a secondary STT change, which you see in a typical left bundle branch block pattern, which is what a RV apical pacing generally shows as well. So these are all the areas which you need to look into to identify is there any abnormality. And that's where in this ECG, what we see is that there is a ventricular pacing spike, but now you see the pacing spike is pretty small as compared to the previous ECG. In some of the leads, you can't even identify the pacing spike well. Therefore, a 12-lead ECG is important to know that there is a pacing spike. Often in a monitoring lead or a Holter monitor, you might not see the pacing spike. And therefore, a 12-lead helps you that this is a bipolar pacemaker, and it's not only capturing the ventricle, but it is capturing the atrium as well. So you have a dual chamber pacemaker pacing the atrium and pacing the ventricle. What does it tell you? That tell you that it is likely that this patient has underlying sinus node dysfunction, and therefore he has a dual chamber pacemaker. He is likely to have an AV nodal disease also, and therefore, because the pacing rate is equally important. You find out that the pacing rate here is 60. So it's set at 60. At 60 rate, the atrium is paced. So likely he has some kind of a sinus node dysfunction, or predominantly a sinus node dysfunction, and also an AV nodal disease. So you can find out what the underlying reason also is. But can you very definitely say that what mode of pacing it is? Let's look at this ECG. We find that there is a pacing spike. We find it is capturing the atrium, the P wave is seen, and then we find an intrinsic QRS complex. So it's an atrial based pacemaker is what we can say, but it would be hard or not definite to say that this is only a single chamber or an AI pacemaker. The AI pacing is definitely seen, but you need to realize that these days we believe in pacing the ventricle as less as possible, because ventricular pacing, especially in the RV apical conventional position, is not necessarily a good thing for the heart, because it gives an LBBB like effect, and some of these patients, if they have a chronic RV apical pacing, this LBBB can translate into mechanical inefficiency and LV dysfunction can set in. So the current understanding is that minimize the ventricular pacing as far as possible. So this can be an atrial based pacemaker for a sinus node dysfunction, an AI variety of pacing, but it can also be a dual chamber pacemaker where your AV delay has been programmed in a manner that you promote intrinsic QRS as much as possible. So though on an ECG you find out that this AI pacing mode, he could still have a dual chamber pacemaker. This again is a Holter strip in a patient who had a pacemaker, and intermittently he'd been complaining of tired and fatigued feeling. And what we see in this bottom strip here, that the pacing rate is going on at 85, 86. It's a little variable rate, and you can clearly see that the P wave is being sensed, and then a ventricular pacing spike comes up and a QRS capture is happening. That means the ventricle is tracking the atrium. So it has to be a dual chamber pacemaker wherein the P wave is being sensed and the ventricle is being tracked. So this A sense, V pace, that's what's happening. But at other times, we see suddenly the P wave is not being tracked and it goes back to so-called a lower pacing rate of 60 beats a minute. So what's happening here? There is some sort of an under-sensing of the atrial lead. So the atrial channel is under-sensing, and this is something which is more common with a VDD kind of a pacemaker, where you have a single lead, atrial sensors are floating, and 10 to 15% of the times you will have under-sensing of the atrium in these patients. And what you need to do is program the sensitivity. You program the sensitivity to make it most sensitive so that you are able to sense the P waves. Or even in a VDD pacemaker, you can use two separate leads and sense the atrium more appropriately. Let's look at another example. What does this show? Again, a 12-lead ECG. You have a P, you have a pacing spike, a ventricle is being captured. So A sense, V pace is happening, A sense, V pace. For 3 complex, the fourth one, there is a P wave, there is a pacing spike, but there is no ventricular capture. So there is a capture loss. So loss of capture is happening. It's interesting that in this ECG there is a repetitive pattern that after every 3 complexes you kind of lose of ventricular capture. But let's look at various possibilities when you have a loss of capture. Either it could be high thresholds, and high thresholds can be related to lead issues, either a lead insulation or a fracture. There could be certain tissue factors. Drug, electrolyte, ischemia also can raise the threshold. So you program the pacemaker at a particular output, but you may have to reprogram it to a higher output to allow a consistent capture all the time. Of course, a lead dislodgement or a Twiddler syndrome, which is also like a lead dislodgement, can lead to rise in thresholds or loss of capture altogether. But when you have a repetitive pattern like what we saw in the example, it is more likely an exit block from the lead tissue interface. One more example of a situation where you have a pacemaker ECG. You can see a pacing spike randomly occurring anywhere and looks like intrinsic QRS complexes. How do you interpret this ECG? Need to look at it more carefully. You will realize that in one complex, you are seeing two pacing spikes, and the second spike is capturing the ventricle very well. So the ventricular pacing seems to be happening appropriately, but what's happening to the atrial pacing? And probably this is an atrial spike not capturing the atrium. What's happening to the second spike? Why is the second spike not coming? And it can be confusing. This can be often sorted out in a clinic or an outpatient setting by using a magnet mode. You put a magnet on the pacemaker, it will go into a asynchronous mode, VO or a DO mode, and that will help you to decipher which lead is giving a problem. And in this patient, we had a programmer available to us, so we used the programmer to increase the pacing rate, and we could see that in the ventricle it was capturing very well and the thresholds were quite all right. It was actually the lead was, it was like a silent atrium. If you look at this ECG and the previous ECG, you would realize that virtually there are no P waves seen. It was like a silent or a very fine atrial fibrillation, which is what the pacemaker was detecting at times and not detecting at other times, giving rise to atrial spike often, and the intrinsic QRS was not allowing the ventricular pacing to happen. But in a magnet mode, we realized that the ventricular lead is functioning well. It was the atrial fibrillation which was a problem. And that brings to an important point, that in a pacemaker, to know the underlying rhythm is very important. Yash did mention it yesterday in one of his ECGs. Let's look at this ECG. What does it show? Large unipolar pacing spikes. Difficult to identify QRSs in the limb leads, but precordial leads, obviously you can see that you have a ventricular capture, and in the precordial leads V1, you can clearly see that this is a rapid atrial flutter going on. So identifying underlying atrial rhythm is important, because in patients who have a single chamber pacemaker, often they will go into atrial flutter fibrillation, or for that atrial flutter fibrillation with a complete AV block, one may have put the pacemaker. But in either case, you need to clinically make this decision when you have identified atrial flutter fibrillation, that is this patient in need of oral anticoagulation? What is the CHAD score? What are the likelihood that this patient is at risk of stroke needs to be assessed, and accordingly the patient should be on anticoagulation. The QRS morphology did look very funny in the limb leads here, and the reason is often we do consider pacing not in the typical RV apical location, but in the septum, mid-septum or high septum, so as to get a narrower QRS and therefore not have a marked LBBB and a dysynchrony. So this is what is often used, especially in prior compromised LV function patients, and some investigators do believe that septal pacing probably is a better tool. Often we get this sudden call from physicians who are examining patients with pacemaker implantation, and they have clinically examined the pulse is 50, but the report says the pacemaker has been programmed at 78 a minute, so something is malfunctioning. Well, you should realize that there are many non-palpable PVCs. So best is to take an ECG and accurately determine what is the rate. And the second important part is there is a program called as hysteresis in some of the pacemakers available. Hysteresis again is a feature which allows or promotes intrinsic QRS as much as possible, so as to minimize the amount of pacing and conserve the battery life. Some of you, when you see the ECGs in a single strip or a Holter monitor strip, as I showed you in examples, say that there is no pacing spike seen, but a bipolar pacing spike may not be necessarily visible in a given lead, and you need a 12-lead ECG. And this is just an example where the pacing rate, though had been kept at 60, you suddenly find a long pause here after intrinsic QRS. This is nothing but the feature of hysteresis, that though the lower rate is at 70, you allow a longer duration up to 50 beats a minute after a sensed event, so as to promote more intrinsic QRSs to come, and that way conserve battery life and avoid unnecessary ventricular pacing. Let's move on to certain other issues which we look in a pacemaker patient. A pacemaker patient complains of chest pain. We had a session yesterday and it was talked about, but let me show you one more example of a situation. 6 months later, he starts complaining of chest discomfort. So obviously, you're going to look at signs of ischemia. In a patient who has a pacemaker, you expect secondary STT changes, as you are seeing here in lead 1, in lead AVL, and in the precordial leads. What do you see here? A primary ST change. You have an ST elevation now when he complains of pain in lead 1, which should not happen. ST should be depressed. Same thing in V5 and V6, you have an ST elevation. So a primary ST change in leads where you expect an ST depression, you should suspect underlying myocardial infarction process. And this is one example which Dr. Narasimhan gave me, where a dual chamber pacemaker was implanted, complaints of chest pain. What does this ECG show? Does it suggest that there is an ongoing ischemic process? Anybody? You see the precordial leads, and here in V1, V2, normally in a ventricular pacing with the negative QRS, you are expecting an ST elevation and a T wave which is upright. That is the secondary ST change. But if you see an ST depression of this nature, obviously should make you think that this patient has an underlying infarction process going on, and some of these patients may not be completely needing pacemaker all the time, and you should program in a manner that you can see the intrinsic complexes and you can identify this as an infero-posterior wall infarct happening in this patient. So another important aspect is when the patient's pacemaker comes to end of life, and what we see is the programmed rate, and if you see a drop in pacing rate, that could suggest